sorry, Reema has to leave for another. Can you get Dr. Reema Bansal's talk? She will be talking about a mass in the choroid. Mass in the choroid could be metastasis, it could be tuberculoma, it could be anything. So she's just going to say how do we proceed once we see a mass in the choroid.
Very good morning, all of you. Thank you, ma'am, for this opportunity to speak in your instruction course. So I'll be talking on choroidal mass and what do we have to do, what things we need to rule out. So the first thing that we have to think of is whether it's a tumor. Now when we think of a tumor, it could be benign, it could be a primary malignant tumor, or it could be a metastatic lesion in the choroid. Now the second differential diagnosis for a choroidal mass is it could be an inflammatory disorder, it could be infective or non-infective. The third possibility is any vascular disorder like a choroidal hemangioma, which may be very obvious or which may be subtle, or it could be a hemorrhagic choroidal. And fourth, of course, we need to rule out pneumocus, like which could be non-infective or which could be infective. Non-infective, it could be a fibrin CSF. Infective, it could be an abscess. So coming to the tumors, which could be benign, primary malignant and metastatic. So let's begin with the benign choroidal tumor. So we have this young girl presenting with decreased vision in the right eye for 2 months. Now if you carefully see, there are varying levels of pigmentation in the fundus around this lesion. So you have a hyperpigmentation at the top, you have a hyperpigmentation in the middle, and you have hemorrhagic appearance at the bottom. So you have different kinds of pigmentary levels in this lesion. So when we do a radial scan of the OCT, we have different pathologies that are outlined, shown by the OCT, like horizontal lamellar lines. I'll not go very much into the details, but we see hyperreflectivity, vascular channels, subretinal fluid, and if we go for the OCT angio, there is a choroidal neovascular complex also seen. Coming to the combined fluorescent and ICG angiography, we see there is choroidal neovascular complex which is confirmed, and the ultrasound shows a dense hyperreflectivity suggestive of choroidal osteoma. So this was a case of choroidal osteoma within choroidal neovascular membrane. So coming to the second possibility of a primary malignant mass lesion. This was a young male who presented with a mass lesion in the right eye with decreased vision. You can see there is fluid inferiorly exudative detachment. This is the closer photography on top corner. There's a huge mass lesion. When we do the OCT, there is subretinal fluid, and the scan through the lesion is showing an extreme elevation temporally. A combined fluorescent angiography was done, followed by the ultrasound, which showed the characteristics of choroidal melanoma. So coming to the third possibility of tumor being a metastatic. Now this was a middle-aged man who presented with decreased vision in the right eye. He was a 61-year-old male. He was a chronic smoker. We got his CT chest abdomen done, which showed nodular pleural thickening. Pleural fluid was there, which was suggestive of lung carcinoma. There were non-enhancing lesions in the liver also. The FNAC from the liver showed squamous cell clusters and all the features that were suggestive of metastasis. So this was a metastatic squamous cell carcinoma, and this was basically a choroidal metastasis as the presenting manifestation of lung squamous cell carcinoma with metastasis all over. Coming to the second etiology, which is inflammatory disorders. Now we have to be careful in ruling in infective or a non-infective etiology. So if you have a presentation like this, where you have a solitary lesion right at the posterior bone with a lot of exudation around it, and if you carefully see, there are vessels around or over the mass lesion. We do an OCT, we find that there is elevation of the artery choroid complex. There is subretinal fluid and there is a fibrinous material in the subretinal space. Fluorescein angiography showed hypo and hyper, suggestive of choroidal granuloma, and on investigations we came to know this was a tubercular etiology. So the second possibility is a non-infective inflammatory disorder. If you have these multiple lesions in the fundus, especially in the posterior pole, if you go back, they are not as exudative as the previous one. They are orangish in color. And if you, this was a patient of more skin sarcoidosis and calcified mediastinal lymph nodes. The OCT is very much different from what we saw in the previous case. So these are intrachoroidal granulomas. This was a case of sarcoid choroidal granuloma. So coming to the third possibility of vascular disorders, it could be a choroidal hemangioma. In this case, it's not very obvious, but the patient presented with decreased vision. And if you carefully see, there is a diffuse lesion in the posterior pole extending up to the arcades. The other eye was normal. This is the autofluorescence where we have a good evidence of a lot of changes going on in the right eye. So we do the OCT scan. Again, there is a huge elevation of the RP choroid complex with subretinal fluid. And this is, again, we tried to do multiple scans on the Heidelberg. So the ultrasound showed solid mass hyperechogenic arising from the cones of the eye with high internal reflectivity. And combined fluorescein and IC109 angiogram confirmed the presence of diffuse choroidal hemangioma in the right eye. The other possibilities, if we see muscular lesions, it could be a choroidal detachment, it could be a hemorrhagic choroidal like this. This was a post-operative patient who underwent choroidal drainage of the blood, and this is how, this was the fifth post-op day after drainage of the suprachoroidal drainage. And of course, we need to rule out masculate or the mimickers which are non-malignant, like non-infected. So this was a case, you can see a white spot at the fovea. This patient had chronic progressive loss of vision in the left eye, but there were no signs of inflammation. So we need to be sure about the location. It could look like a choroidal mass, it could look like a retinal lesion. So when you do an OCT, this is nothing but hyper-reflective deposit in the subretinal space. This is not a choroid, but it could be a choroidal lesion. The autofluorescence gives us good clues. You can see there is chronic CSC changes in the left eye. Fluorescein confirms the presence of chronic CSC, and just stopping these steroids led to resolution of the fibril, and the fundus picture is back to normal. So the OCT is also showing disappearance of the fibrillous material. Coming to the infective etiology, which could look like a choroidal mass. This is a subretinal abscess, and you can see a localized choroidal detachment in upper nasal quadrant. There is posterior hypopyon also, and the anterior segment examination showed hypopyon. So this was a patient who had undergone psoas abscess drainage. So this is nothing but a subretinal abscess secondary to psoas abscess. So the key points when you look at a patient with a choroidal mass lesion, we need to have careful history, clinical clues. Imaging is important when, and of course, multimodal imaging gives us the underlying cause. And out of these, the OCT, followed by combined fluorescein and ICG. And of course, the ultrasound gives us characteristic clues. So imaging is important, and from here we can have the correct diagnosis of choroidal mass lesion. Thank you very much.
The differential diagnosis could vary from metastasis, from a granuloma, a tumor, and it could be simply a choroidal detachment like hemorrhagic choroidals occurring after cataract surgery. Our choroidal detachment nowadays, many of the drugs also induce choroidal detachment. So it's very important that when you look at the choroidal mass, you have all these perspectives in mind and go accordingly so that you are not making mistakes. Any questions related to her talk that you would like to discuss with Dr. Reema? Yes.
Choroidal biopsy? Not really. First, we do the multimodal imaging. Unless you're suspecting a lymphoma, we will not do a biopsy.
So what you want to say, suppose there is a lesion which she is unable to pinpoint the cause.
हेलो सुनो बोलना बोलना मैं पूरा बोलता तो बोल सुनो ओके हाँ
Can I answer?
ठीक है यहाँ से
So first, when you look at the mass, if it is a choroidal detachment, that has a very different anatomy. You look at it, you see the annular brown or even the red, you know it is choroidal detachment. It's out of your way. You don't need a biopsy or anything to confirm it. Now the second scenario is you have a mass which you are not sure whether it is infective or non-infective. Infective mass is going to be more yellow colored than the metastatic mass. So if it is a yellow colored mass and it is showing some hemorrhages, some vessels dipping into it, it's most likely infected. TB would be one of the possibilities. In such a case, biopsy is absolutely not to be done because right now whatever the infection is, that is behind the retina. Once you do biopsy, everything comes into the vitreous. Now the third scenario is, it is a tumor. So in the tumors, I would first suggest doing an ultrasound because we are nowadays not paying a lot of attention to ultrasound, which has very characteristic features differentiating hemangiomas from melanomas, from metastasis, you know. So I would first do ultrasound to see if it has any typical features of a melanoma, amelanotic melanoma or whatever it is, and then proceed in that direction. If I suspect hemangioma, I will do ICG and fluorescein to look at the features. Now we are left with a mass which is malignancy metastatic, which we are not able to differentiate where it has come from. So if I suspect that, we will do a whole body PET scan. We will involve our internists to look for this because getting the biopsy should be the last resort once you have exhausted everything else, everything is negative, and you are not able to pinpoint the finger. You know? Once we reach that stage and you don't have a choice, yeah, the biopsy will depend again what are the lesions. There is something called fine needle aspiration biopsy which you do elsewhere in the body in the form of a trochet. So you can go through the pars plana. You can go from inside or you can also go from outside depending on the location of your mass. But it has to be guided by your pre-op imaging. Like where exactly the mass is, what is the depth of the mass, what needle. But believe me, that biopsies do not really yield a very good result because it's a very small tissue. You put a needle into the mass and nothing might come out. You know, even something comes out, the histopathologist does not get it. You know. Those are the situations which are done by oncologists, and I would ask Simon to answer to it. Like from our point of view, we are not really going for that.
Kind of doing it, we take the 27 gauge cutter directly into the melanoma and try and cut it out with a lower cut rate and take that sample. So that is important diagnostically, and also now there is genotyping that is being done with that sample that kind of prognosticates the patient. So that is the only scenario that I am aware of where we do it.
And
That
second is,
also, once you are doing it, you either resect the melanoma completely or you put in a plaque along with it. we need to be relatively sure that that's phenomenon. That is more of a prognostic thing rather than a diagnostic thing. If you are going into, you are prognosticating the patent.
Thank you. Our next talk is by Dr. Manisha Agarwal. Thank you, Reema. She will talk about you see fluid in the posterior pole and you do not know, and it's a very common scenario sitting in the uveitis clinic that patients of CSR are diagnosed as leakage and leakage is diagnosed as CSR. So she's going to talk about how to go about so that we don't make such mistakes.
A very good morning to all of you, and thank you, ma'am, for making me a part of this wonderful IC. And as my talk suggests, we very often see a pocket of serous fluid at the posterior pole, and the most common diagnosis which comes in our mind would be a CSCR. And these are the various OCT scans. I have put around 5 OCT scans, all having a pocket of fluid. But there are very subtle things that we need to register in our mind or notice or observe carefully. And that's going to help us to differentiate between various etiologies, which all resemble in the form that they all have a pocket of subretinal fluid at the posterior pole. So this is the classical CSCR where you see a pocket of SRF. And when you do a fundus fluorescein angiography, you are going to be seeing a kind of a leakage of the dye, which we very classically know is either a smokestack appearance or an ink blot. We have learned it over the years. Now let's see some other cases which also have a presentation with a pocket of fluid but are not CSCR. So this is a 34-year-old male patient with a history of chronic CSCR in both eyes and is being followed up by the ophthalmologist. But now he presents with a drop of vision in the right eye. Now what you notice is that these are all the RPE changes which are very classically visible in a patient of chronic CSCR. But now he's presenting with